And I will carry that on by starting straight away. And thanks for coming to this BSH guideline session this morning. So what we've got on the agenda this morning are the three things, really. One is I'm just going to give a brief overview of the BSH guideline process and where we are with that and some of the developments we've been trying to push through. And then we've got two talks. What we do every year is present two of the guidelines that have been published recently that we think will be of interest to you from two of the task forces. And the ones we have today are the thrombophilia testing from DEEPA and guidelines for the diagnosis of malaria from Claire. So as I said, I'll start by just telling you a little bit about the guideline process for those of you who are not familiar with it, and perhaps it will encourage you to become involved later on or even very soon. So the structure of the guideline team is shown here. There's a BSH guidelines executive, which I'm the chairman at the moment, and there will be a replacement deputy very shortly. Replacement required because Guy Pratt has become the secretary of the BSH, so he can't do both things. And the replacement will come almost always or invariably from one of the task force chairs, which are shown in the next line. So there are four task forces: one for hemostasis and thrombosis, one for general haematology, one for hemonc, and one for transfusion. That covers pretty much all the areas we need to. And each of these has a chair and either a secretary or a co-chair. And they also have a number of other members, which are generally designed to represent research, teaching hospitals, but also district general hospitals. So that's a full spread of the haematology community for whom we think the guidelines should be useful. And that will help make them relevant. But we also have some co-opted members who are from things like NECWAS or perhaps NIBS&C, who also have valuable contributions to make to the guideline process. And an introduction we've made the last year is to allow a trainee to join each of the task forces. This wasn't previously the case, and I'll say a little bit about that at the end. And finally, we have behind us help from the BSH admin team, particularly Rita, who's sitting in the front row here, and Anne Ongonjimi, who do a lot of things to help us push the guidelines through, because the guideline process has become a little bit more formalised in the last couple of years. And because it's more formalised, it's more work, and we realise that the people on the task forces generally have other jobs to do as well, and the NHS doesn't, unfortunately, give them PAs and time to do this. So it's mostly pro bono. So what the guideline executive and the teams try to do is a number of things. We write guidelines, obviously, but we also, and those guidelines are for situations where we think there's a reasonable amount of evidence that allows us to make evidence-based recommendations. But I think that one thing the British guidelines do, which other guidelines, and I'm thinking particularly of ASH, for example, does is to try and tackle problems where there is not, give an overview of the general problem rather than try and identify specific questions and only answer specific questions, whereas in fact we know that people out there have many, many more questions than just those cherry-picked items that some of the guidelines approach. So I think they're generally pretty good, and I think they're better than a lot of other guidelines that are around. Where there isn't enough evidence to make a guideline recommendation, there is scope to do what's called a good practice paper, which is really expert opinion. But we'll try and introduce data searches for these as well to make sure that if there is evidence, that it is included. When the guidelines are written, we try to get a commentary written in the corresponding edition of the journal. It's usually the BGH, but not always. And that's to give another perspective, an outside perspective on the guideline. I think that's been very successful as well in the last few years, although sometimes there's a mismatch between, say, an overseas commentator and what we've written as a guideline for practice in the UK, so that can be a problem. But I think we've tackled that. And finally, we have podcasts, which again have been introduced in the last couple of years, which I hope many of you have listened to. You can get them through using the Podbean app, and you can listen to usually one of the task forces, the writing group's summarised account of what's in the guideline, and you can listen to, if you nod off in the middle of this session, you can catch up with the podcast later on. We do a number of other things. So we frequently get communications from NICE. These are often about technology appraisals, where we're asked to give opinions on things, but actually bigger things as well, like the NICE guidelines. So we get those, interestingly, through the RC path rather than the BSH directly, but they do come to us and we do try and respond to them. We try and keep up with other guideline writing groups like ASH and EHA, and we do have meetings, usually online meetings, with these groups 2 or 3 times a year. This helps us align what we're doing, helps us exchange ideas, topics, ways of transmitting the guidelines out to the community, getting feedback on them, and so on. And also helps us to avoid overlap. And in fact, one way of tackling the overlap, which we've arrived at recently, is to write a joint guideline. So with EHA, we recently published a joint guideline. I'll mention that again later. And during the COVID-19 pandemic, the guidelines you saw, the updates and practice recommendations on the BSH guideline, BSH website, were almost entirely from the guideline groups. So that was very productive. Interestingly, they've nearly all gone now. We've taken them down instead of being out of date. If you want to find out more about the guideline process, you can go to the BSH website, and here at the top you'll see guidelines. And if you go down, you'll see a link in the website to proposing and writing a new BSH guideline, and that will take you to this page where you can find links to an induction tutorial, proposal form, and the guideline development process, and it will take you to a page like this, where it's all set out for you. And there are quite a few important things about the process that you need to know, because any of you can propose a guideline topic if you think it's important, and that will go to the relevant task force, and the task force will take it through a number of steps for the proposal, which are outlined here. The things to note here are that the task force will have a representative on the writing group, but they needn't be the chair or the lead of the writing group. And many of the writing group people will not be members of the task force. They'll be from a good balance of District General Hospital and teaching, and maybe the co-opted people as well on the writing group. And we try to get a reasonable balance of people on the writing group, so it's representative of the people who we think will be using the guideline eventually. And that will go through. We'll also add maybe some contact, at least with relevant patient groups. And when it's gone through, they'll do the outline of the guideline. And the admin Rita and Anne, will help you do a literature search. So literature search will be done for you and collated by a medical writer. So that's one thing we've introduced in the last few years, to formalise the literature review to make sure the guidelines are truly representative. And then the guideline group, the writing group, can get going. And there's a process here, which I won't go through in great detail, except to say there's a series of steps where it goes back and forward. And this requires a lot of meetings. And again, the administrative help from the BSH is very valuable in getting those meetings together, because it's actually previously it was impossible, and the guideline writing time sort of expanded where people were unavailable and so on. So help in organising the meetings is invaluable, and the literature review does have a lifetime on it. It's only got a year's lifetime. So if you don't get it done, you have to go back and do the literature review, and then you have to review, go through all that again. So it does help. And eventually the finished guideline is sent out to the various other task force members, and eventually it appears on the BSH website, because the sounding board for review is everyone who's in the BSH. And then it goes out to review. The journal won't take our word for it. It just go out to a formal review, and then hopefully it'll be published in one of the Wiley journals. So just to give you a view of what the magnitude really of the effort, I'm just going to show you some brief slides of the different task forces. So here you've got the General Haematology Task Force. You can see they've got 8 guidelines in process at the moment. These are being written now. And the Haemostasis and Thrombosis Task Force has got 7, and some good practice papers in there you'll see alongside the guidelines. Transfusion's got 10, and Hemonc have got 9. So there's really a lot of work going on all the time to write these guidelines. So the total number of guidelines on the website is about 60, and the task forces review these and see if they need updating or archiving. And when you think they need updating, you can either rewrite the whole thing, or maybe sometimes we'll put an addendum on the bottom, and you'll see that on the BSH website when you go there. Just a little update, a little bit of extra data. And I think they're enormously successful. I mean, I've come into this fairly late. In 2016, 2023, 3.5 million downloads. And the total number of guidelines you've just seen in progress is 37. So if you want to see what's going on more recently, these are the download figures from the last 6 months, split into two groups. You can see there's still an enormous number of guideline downloads going on, and some of these guidelines are very recent. So the thrombophilia guideline, obviously you're going to hear in a moment, is very recent. It's top of the list at the moment. But some of them are actually quite several years old, and they're still getting lots and lots of downloads. The podcast's also been fairly successful. You can see here's the profile of the downloads from the website, and it's going up. And what's actually quite gratifying as well is that not only are there UK downloads for these, that there's actually quite an audience in the largely English-speaking world, even in the USA, as well as Australia and other areas. So I think that's pretty good. I'm finishing by just saying a quick word about the most recent developments. These are the task force trainees, which we've included in the writing groups and the task forces. There will be an application process, and Keith has been drawing up some criteria to help us do that. It's a response on our part, I should say, to the requests from juniors to take part in this. But the guidelines are supposed to be expert opinions, and we want to get the right balance between experience and the sort of mentoring process as well. We have devised a scheme, because of the shortage of people's time, to allow retired consultants to come back and help. These are the only people actually who, on the guideline, who will actually get paid for participating. And it's not just because I'm retiring. But we only have one person doing it at the moment, actually. I think that's right, Rita, isn't it? It's one person. So any sort of pending retirement people who might be interested in doing that, let me know. And the last thing to say is that there are lots of guideline writing groups. It's a big industry, not only in the UK, but around the world. We don't want to duplicate things unnecessarily, but things are different in the UK from other places, including the US and large parts of Europe, actually. So it won't always match up, but where possible and where there's an interest, we will try and collaborate with other groups to write joint guidelines. And that has been successful at least once so far with the EHA. But there are problems with this to do with, agreed objectives and local provisions, but also publication in relevant journals, agreed simultaneous publication, what open access means for the different groups and so on. But we will try and pursue that. So the last thing to say is that if you go to www.slido.com and enter these codes here, then you'll be able to answer some questions about the guidelines and give some feedback. So please go ahead. And so having finished that, I won't take any questions to me at the moment. You're welcome to email me or something if you have it. And if you want to be involved in some way in the task forces, then do let me know. You can find me at Imperial College still. And so we should move on, I think. And I'm going to ask to, that's just that. If you haven't got that, I'm going to take a photo of that maybe, to move on. And the next speaker, who I hope the AV will organise for us, is Deepa Arakalagi, who's also from Imperial and is going to tell us about the thrombophilia guidelines. Deepa.
How do I get the slide? Mike, how do I get the slide? I think you have to close that.
Do you have a...
Yep. Okay, good morning, everyone. Thank you for the BSH for inviting me to speak about the thrombophilia guideline on behalf of British Society for Haematology. So I'm speaking on behalf of all my co-authors, as I was the chair and the lead author of the guideline. So this guideline updated the 2012 guideline, which included only the heritable thrombophilia, and the updated guideline include both heritable and acquired thrombophilia. So over the next 30 minutes, I will discuss some of the sections that specially we included as a new sections in the current guideline. So these are my disclosures. So what is thrombophilia? Thrombophilia is a heritable and or acquired condition that predisposes people to develop thrombosis. And sometimes both acquired and heritable thrombophilia can combine together and act as a synergistically to increase the risk of thrombosis. But the guideline focus only the factors that are identified from laboratory testing. So we are not going to discuss disorders like cancer, inflammatory conditions, and obesity or other acquired risk factors that contribute to the thrombosis. And these factors can contribute to thrombosis through multiple mechanisms. So, thrombophilia broadly divided into two categories, acquired thrombophilia and the heritable or genetic disorders of specific hemostatic proteins that we can identify from laboratory testing. So, the heritable or genetic disorders of specific hemostatic protein include most common causes factor V Leiden variant, which is present in about 5% of the Caucasian population, and prothrombin gene variant, again more commoner in that populations, but these two conditions quite rare in the Asian communities. And the protein C, protein S, and antithrombin deficiencies are the anti-clotting proteins that can predispose to development of thrombosis when there is a deficiency. And then multiple genetic factors such as the PI1 mutations also can associate with thrombosis, but we are not going to discuss about these things because the risk associated with these things are not well established. But unfortunately, these things still being tested very frequently, especially in pregnancy. So we come across these type of things. So I would strongly urge people not to do these things because it's actually a lot of cost to the NHS and also creating unnecessary anxiety and burden to the patient. And the acquired thrombophilic defect are mainly antiphospholipid syndrome, paroxysmal nocturnal hemoglobinuria, myeloproliferative neoplasm, and the presence of JAK2 mutations in the absence of myeloproliferative neoplasm also can associate with developing thrombosis. And then the last one, I'm going to focus in the pregnancy. So antiphospholipid syndrome is an acquired, highly prothrombotic autoimmune disease characterized by presence of thrombosis, which can be venous, arterial, or microvascular thrombosis, or pregnancy complication, which can be 3 consecutive miscarriage in the early trimester, that means before 10 weeks of gestation, late pregnancy complications, which can be eclampsia, preeclampsia, or other HELP type syndrome, or unfortunately intrauterine death due to placental insufficiency. In association with persistently positive antiphospholipid antibodies, which can be lupus anticoagulant, anticardiolipin, which can be IgG or IgM, or anti-beta-2 glycoprotein 1 antibodies, again, which can be IgG or IgM. These antibodies, at least one should be present at least 12 weeks apart. The reason we say 12 weeks apart, sometimes these antibodies can present transiently following infections or certain drugs or inflammatory conditions. So we saw that very frequently during COVID, that COVID patients had transiently positive antibodies, but whether they are actually pathogenic still remain to be established. So antiphospholipid antibodies associate with various thrombotic complications. It is the most common acquired identifiable thrombophilia. It can present in about 13.5% of patients with stroke, but if you take younger patients with stroke, we generally find as less than 50 years of age. But again, this age comes to the equations if you actually don't have other vascular risk factors. So even in a younger patients, if you have multiple vascular risk factors, like the patient got diabetes, heavy smoker, presence of antibodies may be mere presence of that and not maybe the sole cause of the thrombosis. So in my practice, I consider whether patient has vascular risk factors or not. And then about 11% of patients with myocardial infarction and 10% of patients with VTE can have antiphospholipid syndrome. So we know about 1 to 2% of patients, 1 to 2 in 1,000 population can develop thrombosis. So out of 1 to 2 in 1,000 populations, about 10% can have antiphospholipid antibodies, which can contribute to the thrombosis. And about 6% of pregnancy morbidity due to antiphospholipid antibodies. And again, 10 to 15% of those women with recurrent miscarriage are due to antiphospholipid antibodies. And antiphospholipid syndrome can associate with other autoimmune disease, mainly systemic lupus erythematosus, and about 30 to 40% of SLE patients can have antiphospholipid antibodies, but not all of them develop in thrombosis, and about 1/3 of those patients can have clinical manifestation of antiphospholipid syndrome, which means they develop thrombosis. But if they have both SLE and APS, their prognosis is much worse than having antiphospholipid syndrome alone. So, why does it matter to identify antiphospholipid syndrome by doing thrombophilia testing? So, this is a trial that is published in Blood 2018, conducted by Pengo et al. Group, and they recruited patients to randomize into rivaroxaban 20 milligram versus warfarin with the target INR of 2 to 3. But the rivaroxaban arm, they gave rivaroxaban 20 milligram if they have renal functions of creatinine clearance above 50, but dose reduced to 15 milligram once daily if the creatinine clearance less than 50. But the trial prematurely terminated. They included all patients who had triple positive, that means presence of all 3 antibodies. The trial had to be terminated prematurely because patients who randomized into rivaroxaban arm developed recurrent thrombosis, mainly stroke and myocardial infarction. So the trial concluded that warfarin is superior to direct-acting oral anticoagulant, although the trial included only rivaroxaban. And then subsequently, MHRA and the FDA and the European Medicines Safety Agency all concluded that patients with antiphospholipid syndrome, especially those with triple positive, should not receive direct-acting oral anticoagulants. So most recently, this was actually published after the guidelines, but it re-emphasized that patients with antiphospholipid syndrome should not receive DOAC. So this is a meta-analysis of all the clinical studies conducted in patients with antiphospholipid syndrome treated with DOAC versus the warfarin. And you can see that those who treated with DOAC, irrespective of the antibody profile, they develop recurrent arterial thrombosis compared to those treated with warfarin. So following the Pengo et al. Paper in Blood, we as a British Society of Haematology, Hemostasis and Thrombosis Task Force published these guidelines about the treatment of antiphospholipid syndrome. So especially I'm focusing the patients with arterial thrombosis, they should not receive DOAC. And then patients with triple positive antiphospholipid syndrome, again, should not receive DOAC. We don't have enough evidence to say in the single and dual, but we do not recommend to start as a new patients presenting with thrombosis who got even single or dual DOAC. We recommend to start an warfarin. So we did a multi-center observational study very recently, which was presented at the ASH last year, which include 500 patients with antiphospholipid syndrome, which is quite a large study compared to previously published studies, because antiphospholipid syndrome is a rare disease. So out of these 500 patients, those who develop recurrent thrombosis, 74, which means about 37.5% of patients develop recurrence, and 65 of them develop recurrence while on DOAC. and they all switched to vitamin K antagonist. And then 9 patients develop recurrence while on vitamin K antagonist, but we do not have their time to therapeutic anticoagulations. And 5 patients increased the vitamin K antagonist, that is the INR target, from 2 to 3 to 3 to 4, and all of them had triple positive antiphospholipid antibodies. And then 4 patients switched to DOAC, but they are non-triple positive antiphospholipids patients. So it is difficult. The most common questions we get, like, should we test all patients with our unprovoked VTE or minor provoking factors who develop thrombosis for antiphospholipid antibodies? So the guideline I mentioned before, we include a table that which type of patients are more likely to develop antiphospholipid antibodies. So those who have a history of autoimmune disease, mainly SLE, and then presence of livedo reticularis, which is a skin lesions that can be present in about 30% of patients with antiphospholipid syndrome, and those who got prolonged APTT before the start of anticoagulations, because most of these patients, when they present with any anticoagulant, can cause prolongation of APTT, and then recurrent thrombosis despite adequate anticoagulation, and those who develop a VTE in unusual site like Budd-Chiari syndrome or cerebral venous sinus thrombosis in the absence of other identifiable risk factors. And history of arterial thrombosis without clear vascular risk factors, and thrombocytopenia, which again present about 30% of patients with antiphospholipid syndrome, and women with recurrent miscarriage, stillbirth, or severe preeclampsia or eclampsia, and cardiac valve abnormalities in the absence of other explanation. So these are the recommendations which included in the current guidelines. Screening for antiphospholipid antibodies is recommended following unprovoked venous thromboembolism because this may alter the management, including choice of antithrombotic therapy, especially those I discussed in the previous slide. Again, screening of antiphospholipid antibodies suggested, so the tone is slightly different, is suggested in patients with VTE provoked by a minor risk factors, as this may alter the management of the patients, including choice of the anticoagulant treatment. Patients with acute multiple thrombotic event and evidence of organ failure suggestive of catastrophic antiphospholipid syndrome, which can present about 1% of patients with antiphospholipid syndrome, should be tested for antiphospholipid antibodies. As antiphospholipid syndrome is an acquired prothrombotic conditions, we do not suggest to screen for people who has a family history of antiphospholipid syndrome with the family members present with thrombosis. It's the most common questions we get when we see patients in our clinic. Should my family members or my children should be tested for these things? So we do not recommend to test for family members who got a family with the antiphospholipid syndrome. So I'm going to move into the paroxysmal nocturnal hemoglobinuria, which is the other acquired prothrombotic conditions which should be tested in a special group of patients. Before I move into the recommendations, I would like to go through a little bit about the how patients with PNH develop thrombosis. PNH is acquired somatic mutations in the PIGA gene, which lead to the deficiency of the GPA anchoring proteins, mainly the CD59 and CD55. These are complement protective proteins. So in the absence of these CD55 and CD59, red cells and platelet are more likely to break down or tend to lyse. And also, in addition to the hemolysis, which lead to release of ferric, and also depletion of nitric oxide, which lead to the endothelial activations, and also the direct effect of ferric in the endothelium, which damage the endothelium, releasing tissue factor, and also it has an effect on the platelet activation. So all these things lead to the development of thrombosis. And also, uh, the, there is some evidence to suggest there is implied fibrolysis due to deficiency of UPA receptors in these patients. So up to 10% of patients with PNH can present with thrombosis. So that may be the first presentation of these patients, and then identify the PNH clone. And it's well established that neutrophil clone size directly correlate with the thrombus development. So the studies show that cumulative 10-year recurrence, cumulative 10-year incidence of thrombosis about 35% if your neutrophil clone size is more than 50% compared to the clone size less than 50%, which is about 5.3%. So these patients most commonly develop thrombosis in addition to the usual site, which include the deep vein thrombosis in the leg or the pulmonary embolism, thrombosis at unusual site like superior mesenteric vein thrombosis, Budd-Chiari syndrome, or cerebral venous sinus thrombosis. So why it is important to recognize this? Because if we recognize this early, these patients can be managed in the appropriate clinical setting, as well as they able to initiate non-anticoagulant therapy, mainly complement inhibitors, very early to prevent the complications. So the recommendation is we suggest testing for PNH in patients with thrombosis at unusual site and abnormal hematological parameters, mainly cytopenia and abnormal red cell indices, or evidence of hemolysis, which means raised lactate dehydrogenase, bilirubin, or reticulocyte count. The reason, as I mentioned, it will change the patient's management in addition to the anticoagulation. So I'm going to move into the myeloproliferative neoplasm and risk of thrombosis. Again, the MPN patient can present with the thrombosis at the usual site, as well as the thrombosis in the arterial circulation, as well as the thrombosis in the venous circulation at the unusual site. So again, thrombosis often precede the disease recognition. That's why it's again important to identify this early. So the JAK2 mutation can present about 95% of patients with polycythemia vera and about 60 to 70% of patients with essential thrombocythemia and the primary myelofibrosis. Again, I mentioned before, isolated JAK2 mutation in the absence of the MPN can present about 0.1 to 0.2% of the general populations. And this has been discovered that about 2.9 to 5.6% of the cerebral venous sinus thrombosis with no MPN phenotype. So the studies again show that thrombosis in JAK2 mutated patients with ET, essential thrombocythemia, and the polycythemia vera can present about 7% and 10.5%. And again, the JAK2 mutation has a higher risk of thrombosis compared to CALA mutations, which present about 2.8%. So how do the patients with myeloproliferative neoplasm or JAK2 mutation can develop thrombosis? So as a result of the mutation in the JAK2, there is a defect in the all cell lines, mainly the platelet, red cells, and the neutrophils, mainly the leukocytes. So the platelet defect can lead to the productions of increased thromboxane and other platelet products, which lead to the activation of platelet. And then the red cell aggregate facilitate further platelet and leukocyte interactions. And release of cytokine and other pro-inflammatory products from the activated leukocyte again interact with the platelet and the red cells and lead to the endothelial dysfunctions. And all this at the end lead to the activation of coagulations and the synergistically patient's factors, which can be other vascular risk factors, and the coagulation activation together lead to the development of thrombosis. So these are the recommendations. we suggest testing for MPN panel, which include JAK2 mutations, we 617F mutation and JAK2 exon 12 and CALA and MPL mutation analysis in patients with thrombosis at unusual site with full blood count abnormalities suggestive of a myeloproliferative neoplasm. And we suggest testing for JAK2 mutation in patients with splanchnic vein thrombosis or cerebral venous sinus thrombosis in the absence of clear provoking factors and a normal full blood count. So it's very important in the absence of clear provoking factors because CVST, for example, mainly present in following oral contraceptive pills, dehydrations, or other vascular risk factors. So again, I would like to focus on the role of heritable thrombophilia and venous thrombosis because this is the most common scenario we get asked from other specialties as well as some of us still try to do thrombophilia testing. So multiple variants present in an individual combined with the significant risk of recurrent thrombosis. But this approach is not being validated, so we are not there to recommend this type of approach in clinical practice. We know the patient history is the most important thing in combination of the clinical history of the patients with simple tests like D-dimer can predict in selected patients who are likely to develop recurrence. So, for example, if we want to stop anticoagulations, we stop the anticoagulation after 4 to 6 weeks. We do the D-dimer in combination with the D-dimer results and the patient's factors. We can decide whether patients need long-term anticoagulation or not. Even if the patient has a heritable thrombophilic defect, when we assess all these factors, we can decide whether the patient need long-term anticoagulation or not. And there is no evidence that presence of heritable thrombophilia influence the intensity or the choice of anticoagulation or monitoring anticoagulant therapy when treating thrombosis except in those with antithrombin deficiency. So there is no role for testing in such situations. The most important thing that if we're doing something that should influence the patient management, we should not do testing for the sake of doing it. So the recommendations on heritable thrombophilia testing to predict recurrence risk of venous thrombosis, genetic testing to identify causative variant responsible for phenotypically identified deficiencies of antithrombin, protein C, protein S should be performed when results will influence the patient's management. Testing for deficiencies of physiological anticoagulants should be performed only after 3 months of anticoagulations for acute thrombosis. Again, because during the acute thrombosis, most of these naturally occurring anticoagulants are low. So if you test in the acute stage, and also more importantly, if the patient's on anticoagulations, and depending on the choice of tests you do, especially if it is clotting-based tests, these results can be influenced by the anticoagulants as well as the acute inflammatory situations following the thrombosis. Thrombophilia and arterial thrombosis, including stroke. There is no evidence to support an association between heritable thrombophilia and arterial thrombosis, including stroke. So please don't test. If someone got stroke and you can ask, should we test for factor V Leiden, protein C or protein S deficiency or antithrombin, there is no evidence. The table I have shown is the cohort studies that has been published. It's not massive studies, but the important thing is that none of these studies show there is a difference between the patients who had the heritable thrombophilia or not. So currently no clear evidence to suggest an additional benefit of thrombophilia testing in patients with patent foramen ovale. So again, as another conditions we get asked from the cardiologists, before the closure of the PF4, should we test for thrombophilia testing? We do not recommend this type of testing in these patients. But importantly, acquired thrombophilic defect, antiphospholipid syndrome, PNH and the MPN increase the risk of thrombosis, both venous and arterial, including myocardial infarctions. So there may be a role in some of those patients testing for acquired thrombophilic defect. And more importantly, we know that patients with arterial thrombosis and MPN, which can present about 60-70% of patients with MPN can have arterial thrombosis. As I mentioned before, the recognition of this was important because that will influence the patient overall management. So the recommendations on arterial thrombosis, testing for heritable thrombophilia is not recommended in patients with arterial thrombosis, as the association between the heritable thrombophilia and arterial thrombosis in adults is weak, and it does not alter the management of the patients. We recommend testing for APL in patients with arterial thrombosis in the absence of other vascular risk factors. In patients with arterial thrombosis and relevant abnormal blood parameters, consider testing for MPN and the PNH panel. Recommendation on stroke. Testing for heritable thrombophilia is not recommended in patients with stroke, regardless of the age. Testing for antiphospholipid antibodies should be considered in young, less than 50 years of age, in the absence of vascular risk factors, as this may alter the management, including the choice of antithrombotic treatment. In patients with stroke, an abnormal full blood count should prompt consideration for testing with an MPN panel and for PNH screen. The presence of PF4 in patients with stroke is not an indication for thrombophilia testing. So finally, I'm moving to the thrombophilia testing in pregnancy complications. So although we wrote the guideline before the ALIFE-2 study presented at the ASH last year, our guideline recommendations is not altered because what is been there before this ALIFE study published is still the same evidence. So the ALIFE study is randomized to pregnant women to receive low molecular heparin thromboprophylaxis throughout the pregnancy compared to the standard surveillance during the pregnancy. So the heritable thrombophilia, they include factor V Leiden, prothrombin gene mutations, protein S, protein C, and antithrombin deficiency. The primary outcome was the rate of live birth, and the secondary outcome was adverse event, including the eclampsia or preeclampsia. And the primary safety outcome was bleeding and other reactions to low molecular heparin injections. So these are the results which was present in the ASH last year. Totally, they recruited 164 women to receive low molecular heparin throughout the pregnancy, compared to 162 standard surveillance. And the mean age of the study group was 33 years, and the most common heritable thrombophilia was factor V Leiden, as you can expect it in these populations included in the study, followed by prothrombin gene mutations and the protein S deficiency. The representation of antithrombin deficiency was very low, and I think we have to consider that as a separate entity, as I mentioned before. So the outcome was observed live birth rate was no difference to the low molecular heparin treatment versus the standard surveillance. Adverse event was reported in 39 women, that means 24% in the low molecular heparin arm, and more or less similar in the standard surveillance group. So, thrombophilia testing should be performed only if the results will alter the management of the pregnancy. So we recommend testing for antithrombin deficiency may be considered in pregnant women with a known family history of this deficiency or evidence of heparin resistance. The reasons, again, identifying antithrombin deficiency will alter the management of the pregnancy. The dose of the antithrombotic treatment, the low molecular heparin, or if the women already got thrombosis, the monitoring and the target, all these things, whether patients need the antithrombin replacement, will alter if we identify this. That's the only reason we suggest these recommendations. In women with history of unprovoked VT, testing for antiphospholipid antibodies should be performed outside the pregnancy. During pregnancy, if we tested, the results will be falsely positive or falsely negative. Lupus anticoagulant more or less become falsely negative because the pregnancy is a prothrombotic situations, and all these fibrinogen and other factor 8 all can lead to the shortening of the DRVVT and the APTT. And the antibodies, it can be either positive or negative. So you cannot really interpret the results. And the pregnancy complications during pregnancy, in addition to the recurrent miscarriage, this is the TIP study which was published long time ago, and I'm not going to discuss all this algorithm of the patients included in the study, but essentially this Forest Plus is showing that presence of thrombophilic defect, heritable thrombophilic defect, did not have any difference of the late pregnancy outcome. So the recommendation on thrombophilia testing and pregnancy complications, we recommend against heritable thrombophilia screening women with pregnancy complications such as recurrent miscarriage or adverse pregnancy outcomes. For women with recurrent or late pregnancy loss, screening for antiphospholipid antibodies can be considered as a result aid the risk stratifications and the treatment decisions. APL testing should be avoided during pregnancy as the results may not be reliable. So in summary, it's only one line. Thrombophilia testing should be done only if the results is going to change the management of the patients. Finally, I would like to acknowledge and thank all the writing group members and also Jackie Wilson for helping taking the literature search, and also Professor Barbara Bain and the BSS sounding board, and all of you who commented as a sounding board when the guideline was placed in the public domain, and also the task force members at the time of the writing of this guideline, and BSH for supporting, and Rita for all the hard work. And thank you for listening, and happy to take any questions.
Thanks very much, Deepa, and for summarising it all in one line at the end. That was brilliant. So we've got plenty of time for some questions, if there are any from the floor. A microphone, which I can't see, should appear. Should have put your hand up. So I'll start. I should know all the answers to these, I guess. But in the situation where you've anticoagulated someone for thrombosis or an arterial problem, and you think you want to know whether they've got antiphospholipid syndrome, you mentioned that the lupus anticoagulant test won't work while they're on anticoagulants, and you're interested in knowing whether they're triple positive or just got antibodies. What's your recommendation about handling the search for a lupus anticoagulant?
Yeah, so I think that's very interesting and important questions that we get very frequently. So the testing should be done only after 3 months of the acute event. And if the patient's on a direct-acting oral anticoagulants, there are several ways of doing this, but none of this testing or the ways being fully validated. So depending on where you work, this can vary. So you can stop direct-acting oral anticoagulant, for example, 48 hours if the patient has normal renal function, and do the test when the level is less than 50 nanograms per ml. And some of my work during my MD at UCL, I did some work and suggest that the levels less than 50, it's very unlikely to affect the results. And also there are other ways of doing, like type and venom test and occurring clotting time. That's why I said depending on where you work, this is not being fully validated and available in all the hospitals. And if the patient's on warfarin, you know that iron are less than 3 generally shouldn't affect, but again, there is a risk if we have weakly positive lupus anticoagulant by diluting the sample with 50% full normal plasma, or some hospital do 80-20, that can dilute the lupus anticoagulant effect, which can produce false negative results. And if the patient's on low molecular heparin, you can do the test at the trough level of the dose. Most of the lupus reagents we use has heparinase, which can neutralize the standard level of heparin present in the samples. So it is tricky, but there are ways, and also there is some test called DOAC absorb. The chemicals that use can absorb the amount of DOAC present in the sample and then eliminate the DOAC effect and can do the standard lupus anticoagulant testing. There are ways of doing it, but none of these being fully validated. So,
Thanks, yeah. So, we've got a couple of questions. Is there a microphone? Oh, thanks very much.
Hello. Thanks for a great talk and a great guideline. Actually, my question was quite similar. So in the guideline, it says consider testing for antiphospholipid antibodies in people with unprovoked thrombosis. So when you say that, what you actually mean is antibodies and lupus anticoagulant. So you're stopping. So anyone who's had an unprovoked thrombosis, you'd stop the anticoagulant for 2 days and test them for lupus anticoagulant.
Not essentially if the patient's already got the solid phase antibodies, which should not affect based on the patient's acute thrombosis or whether patient's on anticoagulations, and especially if they have IgG antibodies, high levels, I don't think we should wait for the lupus anticoagulant to be tested. These patients should be started on warfarin. If the only situations like those antibodies not being detected, then there is a role for considering stopping anticoagulations for 2 days and doing it. But I think the lupus anticoagulant is a misnomer. It is an antibody that actually affects the clotting-based test. So it doesn't, as we all know, doesn't cause the anticoagulant effect. It's only in vitro phenomena. But this is actually phospholipid antibodies against the phospholipid binding proteins.
Okay, thanks. 2 questions. Yeah, thanks.
Thank you for the great presentation. I want to ask, how do you manage ABL positive patient during surgical intervention? ABL triple positive patient during surgical intervention. And this patient would receive anticoagulant prophylaxis. Is it DOAC or warfarin?
Sorry, APL, but no history of thrombosis.
He already a patient of triple positive and on medication, and he is planning to do surgical intervention.
So just to clarify, patients got antiphospholipid antibodies, no history of thrombosis, but going to have a surgery.
Yes.
Okay. So it's again very important question. People with antiphospholipid antibodies, we generally call APL carriers, are likely to have thrombosis, especially if they develop another risk factor. So it's a 2-hit hypothesis. So presence of antibodies has a baseline risk. So if people exposed to the second hit, which can be surgical stimuli or inflammation, or for example, women oral contraceptive pill, that baseline risk goes up above the threshold and can develop thrombosis. So in such situations, we recommend thromboprophylaxis, and generally we recommend low molecular heparin thromboprophylaxis unless patient is fully mobile.
Okay, and there's another question further down. If you put your hand up, the microphone will come.
I have a patient. She's a 40-year-old lady.
So hang on a sec. If you have the microphone, then everyone can hear the question.
A 40-year-old lady is having a splanchnic vein thrombosis. We have a normal full blood count. JAK2 is positive, but allele burden is 2%. Is it significant? Does she need long-term anticoagulation, or is it only 3 to 6 months anticoagulation?
So patients doesn't have other risk factors?
No.
So I think irrespective of the JAK2 present or not, if there is no other vascular risk factors and a young woman, I would anticoagulate long term. But of course, it's good to monitor that patient because as I said before, the thrombosis can present earlier, and these people can progress into develop the disease later on.
Okay.
And also, I don't think I have patients who initially presented with the cerebral venous sinus thrombosis found to have antiphospholipid antibodies and patients on warfarin, but I realized her MCV when she presented was 69 and someone has given her iron. And then a few months later, when I saw her second time, her hemoglobin gone up to 150 with hematocrit of 52. And I did the JAK2 mutations, although it's rare to have dual high, disease process, but she was found to have 39% clone. So I don't think it's like, clear cut. It's based on individual management.
Okay. Well, thanks very much, Deepa.
I think he's got a question.
Dr.
Hope it
Gomez.
is
Okay.
Quick question.
Okay.
So Deepa, so as you said, don't test people once they've had a miscarriage, and don't test people who've had a stroke. Now, the problem we have is that none of the people in this audience are the people who are going to test at that time.
I know.
How are you going to persuade the obstetricians who don't read our guideline or the stroke physicians to actually do the right thing?
Yeah, so I think again, for example, this session, there is a parallel session going obstetric. So I think it's a kind of, I'm not criticizing, but I think this two sessions should be combined. So we're talking to a group of hematologists who actually doing the tests appropriately already, and they are the people who reading the guideline, as you said. I think we need to do more education, but how we going to do as a group, we have to take on individual hospitals, I think. And also, certain hospitals actually go through the individual requests and kind of vet them, which patient should be having the thrombophilia testing. It's a great question, but I don't think we have one answer to overcome that. So as a group, we should do something, because still PI1 mutations and the all these other things being tested during pregnancy, and we get overseas patients, and especially in private sector, even in UK, get tested very frequently. So
Okay.
it's
So
a big
short
problem.
question, very long answer. Yeah, I know the question was short. That was fine.
Yeah, Chigit always
I think
asks
I think there's a role for the
answers.
task forces actually to make sure that the guidelines that are written include these other organisations, so that they're all in line and not contradictory. I know things like the recent intervention anticoagulation guideline with the GI people helps, and the RCGL.
And again, Mike, the thrombophilia guideline, we have obstetricians. Lucy is obstetrician from Oxford, and Arvind is a neurologist from UCL.
Yeah. No, I think that's probably the way.
And Jayshree, of course,
But,
pediatric hematologist. So we try to include the other specialties, and maybe through them we can do more education.
Right, and parallel guidelines not the way. I think we've got to move on, unfortunately.
Thank you.
So thanks very much, Deepa. And now it's a pleasure to welcome Claire Rogers from the London School of Hygiene and Tropical Medicine, one of our few malaria reference centres, to talk about guidelines for laboratory diagnosis of malaria. Claire.
Lovely. Thank you very much to Mike, and thank you to Deepa for a really interesting talk, and to the BSH for inviting me to talk to you about the malaria guidelines. So this edition of the guidelines, the ones I'm going to talk to you about today, is actually the third iteration of the guidelines. And before we even start looking, I just wanted to sort of share with you the numbers of malaria, imported cases of malaria, that we actually see in the UK. So how important are the guidelines? So here are the latest figures. These are the 2019 figures from UKHSA. Now, there's been a bit of a lull in figures, partly because of the pandemic, when there was no travelling, so numbers were down, and partly because of the pandemic, because everything's kind of slowed down in terms of surveillance. But you can see in these figures, the 2019 figures, that we had 1,719 cases of imported malaria. It's quite a lot. 86% of them were falciparum, 86% of them malignant malaria. This is a fairly average numbers. 1,700 is about what we see. We see between 1,500 and 1,700 cases most years. And proportionally, we're always seeing about 80+% falciparum. Vivax and ovale, much less. Malari, reasonably rare. We see 1 or 2 Plasmodium knowlesi cases every year. But I want to bring to your attention the number of mixed infections, because we will be coming back to this, less than 1%. So actually we don't really see that many mixed infections. So the guidelines. As I said to you, this is the 3rd edition. So I thought it would be a good idea to have a look at the previous 2 editions. So the first one was in 1997. And this was drawn up because we recognised that there were shortcomings in malaria diagnosis in UK labs. So the guidelines, all the guidelines, are there to support laboratories. They're there for education and to support you to do the best practice. So these guidelines, the 1997 guidelines, recommended that we were examining both thick and thin blood films, that we might supplement the microscopy with other immunological tests. Now, these other immunological tests were actually the very, very first rapid tests. So the very first rapid tests were commercially available in about 1996. It was called Parasite F, and it looked just for falciparum. So it was out there in 1997, but we were suggesting it was used as a supplement to the microscopy. Labs needed to ensure that those carrying out malaria diagnosis were trained, obviously, and that this skill set was maintained. And the recommendation to participate and join a NEQAS scheme was also part of those guidelines. So, 2013, next set of guidelines. Routine looking at thick and thin films. So that's what's recommended. Using the RDTs, of which there were many by 2013, as a supplement to your diagnosis. Accurate malaria diagnosis needs adequate techniques and trained staff. And you need to join NEQAS. Not much change there. So I bet you can't wait to see what we're saying in the 2022 guidelines. Well, would it surprise you to hear that we're still recommending the use of thick and thin blood films, okay? 100-year-old technology here, really state-of-the-art. RDTs can't replace our microscopy. They should still be used as a supplement. We still need adequate techniques and skilled staff, and you still need to be a member of NEQAS and join the NEQAS either parasitology or haematology schemes. So, what's new? I hear you ask. Why are we on our 3rd set of guidelines? Well, because these are out there to support you, we have put more emphasis on methodology. Okay, we have looked at the techniques. We've given you more top tips for doing your blood film diagnosis, both thick films and thin films. We've looked at the RDTs. We've looked and disclosed some of the problems we see, how you can use RDTs best in your practice. Of course, we've looked at molecular methods because we now know that they're being used more routinely with commercial LAMP kits, and we've given you a few tips on how you can QC. We've included differential diagnosis with Babesia. We've given you some images to help with that, and we've looked at the instances where malaria is actually an incidental finding, okay, where it's clinically not suspected. We've clarified the minimum procedure for those labs where malaria diagnosis is quite rare and where staff are doing that on call. And we've encouraged you to use one of the 3 UK reference labs. Today, diagnosis of imported malaria is actually pretty good. That's the good news, okay? Most labs are using one of these and doing some of this. Now, for those labs that rarely see malaria and are losing the skills to do the morphological diagnosis through retirement of staff or just lack of staff, not replacing posts, they want to know, can they just do this? So part of the new guidelines, we've set out this table of recommendations. Okay, we look at the RDT positive for falciparum. What do you do in that case? Well, you immediately look at blood films. Okay, even though you've got your positive RDT for falciparum, you look at your blood films and you do a parasitemia and you report your results. What do you do when you've got a non-falciparum positive? Well, if this is on call, you report your non-falciparum positive, RDT positive. You can look at your films in the morning just to confirm the species. For those instances where your RDT is negative, report that, look at the films in the morning just to confirm. However, if the patient is severely unwell, you should be looking at your films, and the reason for that will become clear as I go on. So why do we still do microscopy? Lab diagnosis should confirm the suspicion of malaria. It should identify parasite species. We want to know what stage of parasite. We need to know the parasitemia, and we need a rapid diagnosis. In 2019, there were 15 deaths from imported malaria. No one should die of imported malaria in the UK. The reason for most of those deaths was delayed diagnosis. So we need to make sure we've got a rapid test that is giving us all the information we need. And we have molecular methods, we've got LAMP, we've got RDTs, but the only method that tells us all of this information is this, the blood film. So we're still using our 100-year-old technology. So I'm going to ask you, hands up, this is the bit you have to, a bit of audience participation here, hands up if you are looking at malarias. Don't be shy, otherwise it's going to be very quiet from now on. Okay, so there's a few of you. Good. Let's see how good you are. Right, okay. So this is my first malaria. I'm giving you a clue and telling you it's malaria here. I'm helping you out. So I want to ask you which species it is. Now what we're going to do, I haven't got Slido or anything fancy. We're going to do the old hands up method. Right, so hands up, have a good look at it. Hope you can all see that. Hands up if you think this is Plasmodium falciparum. Put your hands up. Oh, yeah. Majority of those of you said you were looking. Okay. Hands up if you think it's Plasmodium vivax. Okay. Plasmodium ovale. Plasmodium malari. Something else? Right. So everybody thinks it's falciparum. Good. You're right. There you are. So this is a nice image here of Plasmodium falciparum, very typical. Lots of parasites. We've got more than one parasite in a cell. I haven't got a pointy thing, so you just have to imagine. We've got more than one parasite in a cell. We've got headphones. We've got neat parasites. The red cells are very normal. We've got the little ones that sit on the side of the cells, the acalaiforms, classic falciparum. Right, next one. Same thing. Hands up if you think this is falciparum. Okay. Hands up if you think it's vivax. Oh, couple of you. Yeah, hedging your bets there. Sort of like a half and half. Yep, okay, going with the vivax. Hands up if you think it's Plasmodium ovale. Yeah, couple of you going with the old ovales. Hands up if you think it's malari. No one going with the malari. Something else? Your vivaxes, you are correct. Very good. This is an enlarged red cell. Lots of dots, the Schaffner's dots. Scruffy looking parasite. Classic vivax. Well done. Okay. You can see where this is going, can't you? Right. Hands up if you think this is falciparum. Hands up if you think it's vivax. Hands up if you think it's ovale. Oh, yeah, straight up there. Yep. Hands up if you think it's malari. Oh, yep, couple with the old malaris. Hands up if you think it's something else. Yep, somebody thinks it's something else. It is, in fact, an ovale. Slightly teardrop-shaped red cell. A little bit of spikiness, the fimbriation that's classic of ovale. Big, coarse dots and a nice, neat parasite. Well done for the ovales. Right. Next one. What's this? Now, I apologise, that's a bit pale, that one. But what's this? Hands up for the falciparums. Well, that was almost in the back row there. All right, vivax, ovale, Plasmodium malari, something else. So I've got one person thinking it might be a falciparum, the rest of you, no idea. Is that where we are with this one? Yeah, okay. Let me show you this one then. We'll come back to that one in a minute. Right, what's this? Hands up for the falciparum. Yep, that hand straight up down the back there. Very good. Vivax. Ovale. Yeah, might be ovale. Malari. This is falciparum. I can tell you this is falciparum because this beautiful parasite is very neat, the red cell's not enlarged, and it has little bodies in the red cell cytoplasm. Can you see those little bodies? They're called Maurer's clefts, and they are distinctive and they are diagnostic for falciparum. Let me take you back to this one. Whoops, this one. There we go. This is also falciparum. Notice it's a bit washed out and you can't see those very, very obvious clefts. That's because this slide is stained at pH 6.8, whereas my slide here is stained at pH 7.2. So this sort of leads me on to talking about the sort of emphasis on your methodology, giving yourself the best chance of diagnosing malaria. Now, those two slides, those two images I showed you, it's the same blood. It's just restained. Now, that was sent in to us in the malaria reference lab, and the referring lab diagnosed it as Plasmodium malari. Came in, we had a look at it, we thought, oh, this doesn't look right. We restained the slide, we saw the Maurer's clefts, this is obviously a falciparum, and we phoned the lab. Now, that patient had unfortunately passed away. Now, that's not to say that there weren't other factors involved, but a malari diagnosis and a falciparum diagnosis are very, very different. Okay, so this is part of the making sure that you're giving yourself the best chance of diagnosing. So we want to improve your thin film diagnosis. We want to optimise your staining. So you need to be using GIMSA. So the new guidelines have made it much more specific. Okay, you need to be using GIMSA and you need to stain at pH 7.2. Now, most routine auto-staining methods are 6.8. That's what you use. It makes your eosinophils look gorgeous. But we're not interested in gorgeous eosinophils. We need to be able to see the dots and the clefts that you can only see if you stain at 7.2. Have a look at these images. These are the ones we show you in the guidelines, okay? So you can see they're a bit pale. They're a bit sort of pale pinky orange looking colour. Quite difficult to see the parasites. I particularly draw your attention to the lower one, which looks like the parasite is stretched across the red cell, and that's a very classic look of a malari band form. Look at the same blood stained at 7.2. Beautiful, it's much more prominent, and we can see those Maurer's clefts. And look at this one. Is it a malari band form? No, it's not. It's actually got Maurer's clefts, so this is also falciparum. So the pH is critical. Make yourself up a little bit on the side and stain your malarias manually. The other thing you need to do is minimise contact with air. Now, these are Romanovsky stains, and Romanovsky stains, when you dilute them, once they're in contact with air, start to precipitate. So what you don't want is a blood film with lots of little blue speckles of precipitate all over it, because you're looking for lots of little tiny blue parasites in red cells. So making your preps as clean as possible is a really good idea. And we give a couple of methods for you to do that. We also want to bring to your attention the effect of anticoagulants. Now, EDTA is the best anticoagulant for malaria, but even with EDTA, if you leave blood in your tube, then it will have a detrimental effect on the parasite morphology. And you might end up with parasites that look a bit like this. So this is an extreme. The parasite in the top left-hand corner there is almost completely disintegrated. The one next to it is doing something very odd. This is a falciparum male gametocyte exflagellating. Now, exflagellation occurs in the mosquito gut. So this parasite, excuse me, this parasite thinks it's in the mosquito. It's been in the blood tube too long. It's looking for a female. And the bottom one is a schizont that was ruptured. Okay, so you're going to have 3 merozoites. So leaving the blood in the tube before you make your films is a bad idea. You need to make them within 2 to 4 hours of drawing that blood. The longer you leave it, the worse the effects. The bigger the cell, the worse the effects. So Vivax is more affected. Falciparum, fortunately, less so. And you also need good practice. We want to promote a good practice in examining your blood films. Now, I'm sure you all have fantastic practice, but let me lay out what we would propose. This is a good thin film. I'm sure the thin films that you make look like this. Some of your colleagues out there, however, don't make films like this, and we see a whole range of what I'd like to call interesting thin blood films. It needs to have that nice curved tail end, because that is where you're going to look for your parasites. Don't go down into the thick bit. I know the temptation is to look in the thick bit because you'll find more parasites, but don't. That's what your thick film's for. Stay in that nice area where all your red cells are laying side by side, where you can see whether your red cell is enlarged. You can see whether it's got dots. You can see the parasite morphology. Don't look in the bit where they're all overlapping. You need, ideally, to scan on a 50 or a 60 oil, okay? Scan around. Every time you find what looks like a parasite, up to 100, have a look at it, back to the 50 or 60. Obviously, if you don't have that, you're going to do all the work on your 100. But be methodical. Look at that whole tail end, okay? I know it's a bit of a magical mystery tour for those of you not used to looking at malarias, but be very, very methodical. Now, this area is the area you're going to do your parasitemias in. You only need to do a parasitemia if it's a falciparum or a Plasmodium knowlesi. You don't need to do parasitemias on Ovale, Vivax or Malari. Lots of labs, when we phone a result through, I'll phone through a Vivax and they say, oh, and the parasitemia, you really, really don't need to waste your time doing it, okay? But you do need to be able to do a parasitemia, and that means you need to be counting at least 1,000 red cells, ideally 2,000, okay, to get your estimate. Now, on my microscope, that's about 8 fields on a times 100 objective. So it's actually not that many. It sounds worse than it is, okay? So being able to do a parasitemia is really important, and doing it accurately, I mean, it is an estimate, but as accurate as you can is critical. Right. Encouraging the use of thick films. Now, I know you're all thinking this, okay? Those of you that look at malaria, it's like, no, we can't look at thick films. The thick film is your best friend, okay? We're on a mission with these guidelines to get people using thick films. In the very first meeting, when we all got together, the writing group, everybody said we need to encourage labs to use thick films. They have many benefits, but you have to do them properly. So you need to make a good thick film. That's where we start. 2 or 3 drops of blood over a small area. Otherwise, you're going to be looking forever, all right? About 1 centimetre squared is a good size. You should be able to read print through it, okay? You need to let it dry thoroughly. If it's not dried properly, it will float off as soon as you try and stain it. But don't dry it with heat. So don't put it on a hot plate, because that will fix it and it won't lyse. You can use Giemsa or field stain. The choice is up to you. Both give you good results. But if you are using Giemsa, you need to use it at pH 7.2. So we keep that pH. So imagine you've made your films, thicks and thins. You examine the thick film first. All right? This is to decide whether or not you've got malaria. Then you can go onto the thin film to decide what species you've got. You need to look in the best areas. So if you're looking at a field stain, you need to find areas where the backgrounds are quite pale, like this one, and where the white cells, which don't lyse, of course, are quite purpley in colour. Then you've got a good mix in colour. Don't look in all blue or all pink areas, because your parasites will be blue, the background's blue, the white cells are blue, everything's blue, okay? So look where your white cells are nice and purple. And practice makes perfect. Don't be put off using them. I go out to labs and I say, oh, do you use thick films? Oh, well, we make them. And I say, oh, good. And then we just discard them. That's no use. Have a look at them. And if you look at them every time, you will get better, I promise. Let me show you. This is a thin film. There's the parasite. Took a while to find that one. Same blood. This is a thick film. Now, this is a Giemsa stain. It's a bit more pinky in the background. Here's my parasite. Okay, there it is. I'm sure you can all see that. Oh, here's a few more parasites over here. And a few more. And a few more. And in fact, there's a whole lot more. Same blood. So much easier to find. So a good thick film will increase your sensitivity by about 10 times over the sensitivity of your thin film. It's going to cut down your scanning time. You can tell whether or not you've got malaria. And the sensitivity of a thick film, read by someone who's got a little bit of experience, is 10 to 90 parasites per microlitre. That's better than a rapid test. Okay? So if you can do it, these are really, really good. When you get really expert, you can probably get down to about 5 parasites. Now, of course, we've lost the red cells, so we are going to struggle with morphology, okay? You haven't got, is my red cell enlarged, has it got dots, etc. But with practice, you can do a morphological diagnosis, but actually, you don't need to. You need just to be able to recognise that it's a parasite. And to do that, you're looking for combinations of colour. It's going to have a red nucleus, it's going to have a little blue body, it's going to have some yellow-brown pigment. But I bet you could all tell me what that top left-hand corner is. Falciparum. Yeah, there you go. You see, you're diagnosing off a thick film. What's your problem, okay? You just need a bit of practice. So let's have a look at these with their thin films, okay? So there's our beautiful Falciparum gametocyte. Look at the vivax, okay? Vivax, really big, scruffy trophozoites. Look at them on the thick film. They look the same. They're still scruffy, they're really untidy. And in fact, on a well-stained slide like this one, you see a pink skirt, which is the remnants of the Schaffner's dots. Similarly, that little ovale, with a bit of imagination, I think even you'd agree that looks a little bit oval in shape when you take into account the pink dots around it. And malaria, if we see a schizon, we can count merozoites, so we get an idea of what the species is. So thick films are good, and I would urge you to have a go. Just practice. If you look at every thick film first and then look at your thin, then you get the practice, because you make your diagnosis on the thick, check it on the thin, okay? Rapid tests. Moving on to our rapid tests. Well, these are antigen detection methods, and the antigens that we're detecting are histine-rich protein 2, which is a falciparum-specific antigen. We detect lactate dehydrogenase, which can come as a pan-antigen, i.e. a genus antigen, or falciparum, and there are a few other pan-specific antigens, particularly aldolase. Now, there's lots of kits on the market, and probably if I asked you, you'd be using one of these. Binax Now, which is a combination of the HRP2 and a pan-aldolase. The Optimal, which is falciparum LDH and pan-LDH, and then we have the CareStar or CareUS, as they're called now, which is a combination of HRP2 and pan-LDH again. Sensitivity, this is our sensitivity, 50 to 100 parasites per microlitre. As I said, similar to your thick film, which is about a 0.002% parasitemia. They are good rapid tests. they have revolutionised diagnosis of malaria in endemic regions. Okay, this is why the numbers of malaria cases globally have decreased. So they are amazing in what they've done for malaria diagnosis. However, there are caveats to their use, and these guidelines, we point out some of the issues. So the first problem with RDTs is misinterpretation. So let me just walk through. So one there is control lines up, that's a negative, okay? No lines for 1 or 2. The next one is invalid because our control lines aren't up. Number 3, we've got the control line and the falciparum specific antigen. Okay, whether that's LDH or HRP2, right? That's falciparum specific, so that's positive for falciparum. Number 4, we have nothing in the falciparum line, but we have a line for the genus one, the non-falciparum. So that means it's either Vivax, Ovale, malari. It's number 5 where it causes problems. 3 lines. This is what we see most frequently, 3 lines. Okay, so we've got a positive line for falciparum, the 1 line, and we have a positive line for the genus, the Plasmodium line. In 99% of all cases, this is just falciparum. Okay? In that 1%, it could be a mixed infection. We can't tell. But in most cases, remember how many mixed infections we have every year? This is just falciparum. And this causes labs some problems. We get malaria referrals in, Plasmodium plus another species. And we have a look and we get 2 people looking and we send it off for PCR. And I phone the lab and I say, oh, what was it you saw? Oh, no, we didn't see anything. The rapid test said it was a mixed infection. Absolutely, it could be a mixed infection, but actually it's most likely to be just falciparum. False positives. So we've known that we get false positives with the rapid tests for some time. Rheumatoid factor is a sort of classic example. But those RDTs that test for HRP2, the falciparum specific antigen, HRP2 persists after successful treatment for weeks. Okay, so we can't use those RDTs to monitor treatment or in just treated patients. There are also false negatives. Now, this can be for a variety of reasons. Prozone effect, which is quite rare, and I'll come back to. We definitely know that Ovale is not always picked up. There are 2 subspecies of Ovale, and they're not always picked up by the RDTs. Plasmodium knowlesi, well, the RDTs are unreliable, and I'll talk about that in a little while. And there are now falciparum parasites that have a mutation and have no HRP2 or 3. So they're falsely negative. Let me show you. So this is an RDT that we've run. We've got 3 lines. So this is falciparum or mixed. Okay? This is an LDH-based RDT. This is an RDT that looks for LDH and HRP2. Notice no band where the HRP2 is. So the diagnosis from this RDT is non-falciparum malaria. Quite different. And that's because this blood had an HRP2 deletion. So HRP2 and 3 are expressed at high levels in asexual stage parasites, particularly in the young rings. Now, this is an ancient gene. It's highly expressed, but we don't actually know what its function is. It may have something to do with cytoadherence, but we're not really sure. We've known about deletions in the HRP2 gene for some time, but it wasn't till about 2008 when we had field isolates that were shown to have these deletions. Now, these isolates came from Peru and neighbouring countries in the Amazon region. Today, we know that there are HRP2 deletions in malarias that are coming from areas in Africa, including Eritrea, Tanzania, the DRC, Sudan, Kenya, Rwanda, and also some from Odisha state in India. However, I don't want to put you off using your RDTs. In most cases, they're absolutely fine. They're appropriate. You just need to be aware, okay? And in fact, the WHO have guidelines for this. I've given you the link there, where they look at situations where you might want to change your particular RDT. Excuse me. Now, I thought I'd just show you a few more cases that came through the reference lab that we investigated. So I've given you where it came from, RDT result, what we saw when we looked at the microscopy, whether it was proven on PCR and whether it had a deletion. So the first one, Sudan, the RDT said non-falciparum malaria. The submitting lab called it a vivax. We looked, falciparum trophozoites. What happens is the lab is swayed by the RDT, okay? It says non-falciparum, they look down, even though if they looked at that film first, they'd have probably gone with falciparum, they're swayed by the RDT. Proven by PCR. Next one, Uganda, again non-falciparum, the lab. They weren't sure, they said vivax and or falciparum. It was a 24% falciparum. It was wall-to-wall falciparum, this one. We didn't do PCR, we were pretty sure what we were looking at. The next one there, Ethiopia, again, non-falciparum on the RDT. The lab thought it was a mixed infection of falciparum and malari. We didn't see the films, but on PCR, it was just falciparum. And then we've got Sudan again. This time the lab said it was just malaria parasites. They were hedging their bets. They weren't really sure because the RDT was negative. Again, just falciparum. And then the last one, really interesting, this was a negative RDT. The lab definitely saw malaria parasites and sent it to us saying, we've seen parasites. It was just falciparum, shown again by PCR. Let me show you the results of the HRP2 analysis. These three had the gene deletion, okay? So these three, if you were just going on your RDT, would have been diagnosed as non-falciparum. More interesting are these two. We really don't know what's going on with that case in the Zambia. Possibly it was a low parasitemia, but we did find the parasites. It was findable. We're not really sure. So that one remains under investigation. But this one's interesting. This one was negative for falciparum on the RDT, but on the blood film, 24%. That's quite serious. This is the prozone effect. This is where you have a high number of antigen that just kind of blocks all the binding sites, and you get this false negative. So just bear that in mind when you're thinking about your RDT results. This is why it's so important that you follow it up with looking at your films. Let me show you another interesting malaria. This is one we're in the process of writing up at the moment. Okay, so lab sent this one in. It's got quite a lot of parasites. It looks a little bit like malari here. We've got a nice gametocyte in this slide, in this image. Looks like malari. Below it is a little parasite that looks a little bit like falciparum. It's got what appear to be Maurer's clefts. So the lab looked at this, thought it was malari, then did their RDT that came back as non-falciparum. So they felt fairly happy, except that they'd seen these parasites that looked a little bit like falciparum. So they sent it to us and we did some RDTs. We don't usually do RDTs as a routine, but we did them here. Notice the first one, 3 lines, falciparum. Okay, that's an LDH-based RDT. Second one, we've got a big stonking line on the non-falciparum, nothing for falciparum. So is this an HRP2 mutant? The third one, with the eye of faith and a bit of squinting, you'll see that there's a very faint light in the non-falciparum. So is this HRP2 deletion? No, it's Plasmodium knowlesi. Now, for those of you who don't know, Plasmodium knowlesi is a primate malaria. It's a monkey malaria, and we know you see it in humans. We get 1 or 2 cases a year, and it is unreliably detected by your RDTs. Sometimes they'll come up as falciparum, Sometimes they'll come up as negative, sometimes they come up as non-falciparum. So just be aware that that could be the case. And that's where molecular methods come in very
Claire,
useful.
we're actually 10 minutes over, so
I'm so
over
sorry.
time. So we need to round up, I think. Although there's nothing coming in, I think, after us.
Oh,
You
I'm
could
so sorry,
zip
Mike.
through.
I didn't realise we were so near. I can't see the clock there.
No, there's no clock, I'm afraid.
Molecular methods, just let me show you this molecular method. The alethea, this one is sitting between an RDT and more sort of PCR-based methods. It is commercially available. It has good sensitivity down to about 1 or 2 parasites per microliter. We are finding labs are using this because you get results in less than an hour. Okay, this one, the alethea, is just genus specific. Okay, so laboratory directors who you don't see very much malaria, where you're losing the skill set for your morphological diagnosis, this is something you might consider. So I'll just hop through that. That was LAMP. These are other things in the guidelines. I'm almost done, I promise. Use a reference lab. We're there to support you for surveillance and diagnosis. Final thoughts, okay? Blood film examination is essential for malaria diagnosis. There's no doubt that other methods give you increased sensitivity. They allow you to diagnose morphologically identical or difficult species, so Knowles eye, for instance, facilitate automation. They don't require expertise like the RDTs, but we can't use them to follow treatment or in just treated patients. It's difficult to tell if you've got residual DNA or it's a relapse. Definitely the RDTs give us false positives and negatives. And any morphological scientist will tell you that if you use PCR, you only find what you're looking for. Okay? How exciting is looking at a blood film? You find all sorts, okay? Not just the one thing you're looking for. And this is from me. We are in danger of losing the morphological skills for diagnosing malaria. As my sort of generation of biomedical scientists kind of head off into the distance to retire, okay? We need to be educating and training those biomedical scientists and registrars and clinicians coming behind us and maintaining those morphological skills. So acknowledgements for the rest of the team in the writing group, and I'll stop there. I am so sorry I overran.
No problem. It was absolutely fascinating. If there are any pressing questions, we'll take them. I was going to ask. Yeah, Taku. I think you have to stand up and... Oh, no, it's coming. It's coming.
I'm one of the haematology consultants at Hillingdon, very near Heathrow. So we do get a lot of... I'm one of the haematology consultants at Hillingdon, very near Heathrow Airport. So we do have many tourists with malaria coming to A&E. So we do have a lot of our cases going through. But are we finding a lot of difficulty with BMSs, shortage of staff, not able to confidently report malaria out of hours? Is there a move for digital morphology to the reference lab if they're not sure what to do next?
Yes. So we not infrequently receive, you mean like taking a photo, sending it off to a reference lab. The only thing is that's just one snapshot of one parasite, and we would never make a diagnosis on just the one parasite. You really need to be looking around because you might have one that is slightly misshapen due to anticoagulant effects or is slightly unusual. So I would say you'd be probably better looking at maybe something like the alethea for on-call, because as you say, there is a shortage of biomedical scientists with the necessary skills. But sending photos, we always receive photos and we're always pleased to have a look and give you an opinion as to what we think. But we would not make our firm diagnosis just on that.
Okay.
Thank you.
Keith, thank you. You can do more sophisticated digital transfer, can't you? So that you can scan a whole film, for example. And
Yeah, you can do, and then we could look at it, but we aren't getting that. At the moment, we're getting a snapshot, usually with an iPhone. That's what we usually have.
I'm well aware that goes on, yeah. Thank you, Keith.
So I don't look at malaria films. I only look down a microscope if I need to look at a platelet, actually. But anyway, Given that there are, a lack of BMSs with expertise, do you see any role for artificial intelligence in the future to sort of replace us?
Replace us, oh dear. Well, there are a number of methods that we see. People send us methods where you teach, your artificial intelligence to recognise malaria parasites in films. We're not there yet, but there are some reasonably good ones out there. So I guess watch this space. We're teaching artificial intelligence to detect all sorts of things, from cancers to, cytological screens. So probably, not yet, but probably.
I think there might be a trial in the not too distant future.
Yeah. Well, it's danger for all of us, isn't it? There's a couple more questions.
Hi, I'm Alison. I'm a biomedical scientist from Aberdeen. I was just wondering, what's your opinion on rapid tests such as the QBC?
Oh, the QBC. Oh, yeah. Do you use the QBC?
Yeah, we do. Yeah.
Oh, yeah. You must be. I think there's only 3 of you, 3 labs in the UK using the QBC. For those of you who don't know, it's a hematocrit tube, and you use acridine orange to stain your blood, and you spin it in a microhematocrit centrifuge, and the cells partition, and you can see the malaria parasites. For those labs that are expert, it seems that it's excellent. Of the 3 labs that I know of, they are usually quite right with their QBCs, but it's not so easy to introduce, I guess. And it does take some skill to read it. But yeah, certainly the labs that we know of, that you all seem to be quite expert at using it.
Okay, no more questions. Claire, thanks very much. I'm sorry we didn't
You're
get to
very welcome.
hear the end of it. Thanks very much, everyone. Off to your next cup of coffee or next meeting.